this Congress and present on the behalf of great people. These are my conflict of interest. I'm here to present a unique device which is formed by two components. An annular structure that is implanted below at the base of the ventricle, and a central valve which is interlocked with the annular structure. So this is a unique structure that can give us the possibility to implant really at the base of the ventricle. Implanting at the base of the ventricle gives us the possibility to have an inverse remodeling of the mitral annulus, stabilization like a surgical valve, low profile in the ventricle, only 13 millimeters. This is an outflow tract of a pig heart. And more important, we are able to capture, to jail the anterior leaflet in order to reduce the risk of systolic anterior motion. This is the procedure. Standard transeptal partion is performed, and again, a device is coaxially inserted into the ventricle. We have an anterior arm and a posterior arm. With the posterior arm, we are able to navigate across the subvalvular apparatus and then snare the guide wire. Afterward, we implant the two annular segments. After this, it's only an implantation over the wire. The valve is inserted, the connecting arms are connected with the valve delivery system, and now we are able to pull towards the base of the ventricle and implant the valve. I'm here to present the result of the Cassini-EU study, where up to 30 subjects will be treated, where technical, safety, and performance endpoint will be evaluated. The mean age is 71 years old. The patient were high risk for surgery, 6.1 STS. The mean ejection fraction was 45. One third of the patient had pulmonary hypertension. And more important, if you look at the dimension of the annuli, were 131 perimeter, meaning that we have a valve of 28 millimeter, and we were able to treat patients with more than 40 of annular diameter. Here, we have treated 12 patients, and in 11 we have technical success. We have one conversion to surgery at the very beginning of our experience. The loop formation, it takes usually 53 minutes. And again, these are the first cases, so we check everything twice. And the valve implantation lasts for 37 minutes. No mortality, no LVOT obstruction, no stroke. We had one vascular access complication and one pacemaker implantation. As you can see, the mean valvular gradient remains stable over the time, and no MR is present at 1 year. All the patient experienced, I would say, a stable ejection fraction, despite at the beginning they have severe mitral regurgitation. So, more important, reverse remodeling. And what we think is unique of this valve, the stroke volume increased over time, meaning that maybe that the positioning of the valve at the base of the ventricle gives a better performance of the ventricle, and clearly the pulmonary systolic pressure went down. All the patients experience a better quality of life as expressed by NYHA class and KCCQ and 6-minute walking test. Here again, if you can find similarities, here is the anterior and posterior arm, and here are two other devices which are very similar. So this procedure, it seems that you already know how to implant or to do. This is the phase of implantation, where you have a partial failure of the valve, and then under rapid pacing the implantation. Again, another characteristic is the capture of the anterior leaflet. As you can see on the right side, we will have a case presentation tomorrow. The anterior leaflet is jailed, so there is no problem of SEM. This is a preclinical study in an animal. You can see that the anterior leaflet could not go in the LVOT. This is the mean LVOT gradient in our implant data, and this is a final result. As you can see, and I want you to look at, the valve moves with the ventricle. So especially in patients that have maybe low ejection fraction, it could help the physiologic movement of the ventricle rather than constraining it. In conclusion, we are trying to demonstrate that our valve has a unique design and is able to give us better ventricular performances. In any case, 12 patients have been treated in a reproducible way in EU, and a parallel study in US will begin imminently. And again, we were able to eliminate MR with a positive impact of functional status, including quality of life, 6-minute walking test, and NYHA classification. Thank you.